Screen is visible, Gunjesh.
Yeah, thank you, sir. Good afternoon, everyone. Just first of all, I would like to thank the organizing team for giving me this opportunity. And I have been given this topic, clinical-pathological feature and response to therapy in this novel NRG1 fusion-driven lung cancers. So this study has been published in June 2021 in JCO. And just coming to the introduction, that we all know that gene fusions are quite common in lung cancer. We all know about the ALK, RET, ROS fusion positive lung cancer. And this NRG fusions are relatively recent addition to this list of fusion oncogene. So this is a transmembrane chimeric oncoprotein. You can see that the EGF-like domain is attached to NRG gene, and they heterodimerize with either HR3 or HR2 to further activate the downstream pathway. So these fusions are quite uncommon in lung cancer and has already also seen in breast cancer and pancreatic cancers. So because of this rarity, the behavior of these patients are not known. So this global registry was thus established to characterize this NRG fusion positive lung cancer in the largest and most diverse series to date. So what they did, they collected data from June 2018 to February 2020 from 22 different centers of 9 different countries from the patients with pathologically confirmed NRG fusion positive lung cancers. So in these case series or case reports, they diagnose this NRG fusion either by DNA-based, RNA-based next-generation sequencing or by FISH. So they collected data of clinical, pathological, molecular characteristic of patients, response rate with different treatments, and they centrally curated and analyzed the data. Apart from that, they also collected data of PD-L1 positivity. The PD-L1 expression was seen by IHC, and patients whose tissue underwent sequencing using just single NGS, that was MSK impact, in those patients, tumor mutation burden was also seen and analyzed. Regarding outcome, the data was collected and the several endpoints were progression-free survival, overall survival, and response rate. So coming to demographic, so these fusions were commonly seen in female, in Asian group of patients and never smokers. You can see the early stage, it was quite common, and it was around 50% of patients were of stage 1 and stage 2, but eventually they had a metastatic disease. Adenocarcinoma was the commonest histology seen, and among adenocarcinoma, invasive mucinous was the commonest histology among these group of patients. If you see the metastatic site, the intrathoracic site was the common, and lung being the commonest site of metastatic disease, followed by bone, brain, and lymph nodes. This is the Kaplan-Meier curve of overall survival in these group of patients according to their stages. In stage 1, so median follow-up was 32 months in these patients, and in stage 1, the median OS was not reached, while in stage 2, it was 53 months, 78 months in stage 3, and only 15 months in stage 4 of stage 4 patients. So as I told that they used either DNA-based, RNA-based, or FISH for NGS or FISH for the diagnosis. So among them, RNA-based testing was the most common method that identified NRG fusion. So this is the surplus plot that is showing the NRG fusions and their various upstream partners. You can see the intensity of red bar in the inner circle, and they represent the frequency of each fusion events. The darker the red bar representing the more fusion, and the lighter bar representing less fusion. So CD34, SDC4, and SLC3A2 were the commonest fusion partner among them. So this pie chart is also showing the same thing. Regarding immunophenotype, PD-L1 expression was known in only 42% of patients, and among them, the expression was not seen in 72% of patients, and only 4% of patients had more than 50% of PD-L1 positivity. This is the Wallin plot. Again, it is showing that tumor mutation burden was quite lower in comparison to other fusion positive lung cancer. Median was 0.9 only, while in comparison to other fusion partners, it was quite lesser. Coming to activity of different therapy, they found that the response to platinum therapy In the first line, taxane therapy. In the second line, also they have used chemotherapy in addition to immunotherapy and targeted therapy pan-EGFR inhibitor TKI, that was afatinib. And they found that response rate was not that good, only 13 to 14% with chemotherapy and 20-25% with either immunotherapy or the targeted therapy. So the median PFS was 5.8 months to 2.8 months in TKIs. So the most common response rate was progression of disease only. 40% to 60% was seen in this group of patients. If you see the data of immunotherapy, single agent immunotherapy was given in few patients and the response rate was not that good. The reason could be the low expression rate of PD-L1 and the low tumor mutation burden which was seen in these group of patients. The swimmer's plot is showing the same thing. The clinical benefit was limited in all these group of patients. So coming to conclusion, these group of patients, that is NRG fusion positive lung cancer, are molecularly, pathologically, and clinically more heterogeneous. They have diversity of fusion partners, and we have seen the commonest fusion partners. RNA-based sequencing should be used, and which can maximize the likelihood of diagnosis. PD-L1 positivity rate is quite low, and they have low tumor mutation burden, which will be the reason of poor response to immunotherapy. And for the response to chemotherapy and targeted therapy with afatinib are not that good. Quite limitations are there, like retrospective nature of the this study and reporting bias and lack of prospective sequencing data could be the limitations. That's why further studies for new therapeutic studies are required and the need of. Thank you so much.
Thank you, sir. Now I'd like to request next speaker, Dr. Shashank Das from Navi Mumbai.
शशांक दास है क्या?
Dr. Shashank? Dr. Shashank, are you there?
Yes, I can't share my. Am I audible?
Yeah.
Yes, you're audible.
And is my screen visible?
No.
No.
Wait just a minute.
Shashank, do you want us to share your slides?
Yes, if it's possible.
Please share the slides.
Yeah, we are sharing your slides. You should tell